Director of Nursing, Amy Wood. And we are thankful. Let me just say thank you so much for you and your team and your efforts in helping us stay safe over these last 18 months and the work you've already done this summer and to start the school year. So thank you very much.
Thank you.
Nurse Wood, if you would, kind of walk us through where we are with DHEC, just kind of where we are currently with quarantines and isolations, and catch us up with all that information, please.
Sure. So we started today, our first day of school. I need to be louder. It just needs to be shorter. We started today, our first day of school, with just over 500 students already out in quarantine or isolation. So that means they missed out on their very first day of school. Over 500. We added another roughly 150 to 160 today. When I came down to the meeting, it was at 150, but the nurses have been continuously updating things just since we started this. And so it's going to be about 160 that we add to that number that have been quarantined and isolated. So we are starting in a very different place than where we started last year in terms of the impact to our students. And I just wanted to start out with letting people know why we do contact tracing, because there seems to be some misunderstanding as to, are you doing it because there's funding tied to it? Are you doing it because it's just a policy that the school came up with or the district came up with? And I want to point out that it actually is law. So DHEC has the weight of law, and you can find that where, as it pertains to us in this particular situation, in 44-1-140, and it specifically instructs DHEC to, for lack of a better way of saying it, determine which infectious diseases and communicable diseases need to have action taken and what those actions are. And so Regulation 6120 is a very long document that goes into detail about a lot of things that DHEC does in terms of communicable diseases. The section that pertains to schools is really Section 12. And that, the main thing that it does is it authorizes DHEC to annually publish the child and school exclusion list, the child care and school exclusion list. And that is basically the framework for all that we do in terms of excluding kids and staff from our schools based on contagious or infectious diseases. And I will point out that it does specifically say that no superintendent, no teacher, no principal, no parent, no one has the authority to have someone come back into one of these public, private, parochial, or church schools or daycares unless they meet the requirements that DHEC sets forth. And so we are starting with that as our framework of understanding why we do contact tracing now. So this link is one of the sites on the DHEC COVID-19 page. It actually deals with schools and child care centers. All of our guidance documents are housed there. That's what we go by whenever we have to figure out how we're doing something. DHEC doesn't really give us a lot of leeway in us. I don't know if that's me or not, or if that's the storm coming, but DHEC doesn't really give us a lot of leeway in how we can interpret this. In fact, there are really only two things that they allow us to make a choice on, and one of those is whether or not we allow early returns from quarantine in our district, and the other is consideration for 3 positives in a cohort or class within a 14-day period, and everyone being quarantined after that. And so we basically have adopted everything that DHEC has given to us as how we are going to operate. If you have it on your computer, or if you want to look for this website, This particular page, I encourage everyone to bookmark it because it's got great resources and it gives you the revision date for all of those guidance documents so you can know that you are looking at the most updated one. I'm not going to go into isolation because there's really no difference this year than there was last year. Isolation is still someone who has symptoms of COVID-19 or who has tested positive. They are out for those 10 days from the time their symptoms began or their test was collected. If they're asymptomatic, there's no change in that. The quarantine, the biggest change from last year to this year is that a school close contact, that definition has been created and it's been altered a little bit. So for us last year, we quarantined students who were within 6 feet of a positive case during their contagious period if they were there for 15 minutes or more, cumulative or consecutive. Now that has been shortened to 3 feet. So we will be quarantining students in our schools if they are within 3 feet of someone who tests positive for 15 minutes or more, consecutive or cumulative, during their contagious period. So that narrows down how many we hopefully are going to be quarantining. We do have, DHEC says that those who are fully vaccinated do not have to quarantine. They do recommend that they test 3 to 5 days after exposure and wear a mask, either for all 14 days of that quarantine period or until they get a negative test. It is not required. We have a letter that we will send out to parents if their child is fully vaccinated to let them know of the exposure and to let them know of those recommendations from DHEC, but those are not required, so we are not going to enforce those on everyone. Positive test within 90 days of that close contact exposure, that's a PCR or antigen test. It is not an antibody test. So if you have a positive PCR or antigen test within 90 days of your exposure, you do not have to quarantine. However, DHEC says that you do have to wear a mask during those 14 days. If you are not fully vaccinated and if you do not have a positive antigen or PCR test within 90 days of that exposure, you will be quarantined. And you fit that school close contact definition, you will be quarantined. The standard quarantine from DHEC and CDC is still 14 days. As I said before, our district has opted to allow for early return from quarantine whenever possible. There are several options. One is to return after 7 days in quarantine. That requires a negative test. The other is to end quarantine after 10 days. Both of them require the person to have no symptoms during that quarantine period. If a parent chooses an early return option, they are choosing all of the things that come with that. That means they are choosing to have their child wear a mask for the duration of the 14-day quarantine. They are choosing for their child to be socially distant during class and lunch for the duration of that 14-day period, and they are choosing to allow their child to be screened at school by the nurse or someone in the health room for COVID symptoms for the duration of that 14-day quarantine period. They do not have to choose those. If they don't want to choose any of those, we have the 14-day quarantine. No one is required to come back early from quarantine. I want to point out that although we allow that at the district level and we have given our schools the knowledge of what they need to do, it is not always feasible in every situation. And so we have given the schools the autonomy to make those decisions at their level because they know any restrictions that may exist in a certain classroom or in their buildings. They know the restrictions and the limitations, and we give them the autonomy. We have just said as a district that we allow early returns.
I think one important point of clarity that I see a lot of confusion within the community is the 7-day, at the 7-day mark. So for an asymptomatic person who has been a close contact and has been quarantined, the preferred test is a PCR test, okay? If you do a rapid test, the test sensitivity drops down to about 40%, so it's not incredibly accurate, okay? So if you're asymptomatic, you get a PCR test, but here's the kicker. it normally takes about 2 days to get a PCR test back. And so that's why they say you should not test before day 5, and it should be a PCR test. So it requires a lot of planning, is the point. You know, that if you're a parent who has had and your child is a close contact, you should be planning on a PCR test on day 5 with a return of that negative test, potentially day 6, likely day 7, if you're looking to return on day 8, and it's feasible within the school. And you've had that communication with the school nurse administrators, so on and so forth.
Yes, and that's why when we initiate the conversation with the parent, we typically will tell them, if you are interested, because we can't tell you on the front end that your child can come back on this day because they may develop symptoms on day 3. So there needs to be a follow-up conversation, you know, because if the parent says, well, as long as we stay symptom-free, I would like to, you know, possibly look at that. Then the school can also be planning to see, okay, is this feasible? Because that's not a rapid turnaround decision either. So it's not that a parent can come in and say, look, I read about this, my child got a negative test on day 5, we're here on day 8, and let's go. Because that does typically take some planning from the school side as well.
And I think the important distinction there as well is that this is in response to a behavioral change that the CDC recommended this because so many people were not staying in quarantine for 14 days. Trust me, there are plenty of people who convert on day 13, plenty. And so that's why the symptom screening has to occur between days 8 and 14 is because we know there's a certain percentage that are going to be positive between days 8 and 14, but you would rather have 10 or 20% as opposed to 90% who won't stay in quarantine. And so it was really more of a behavioral change to marry up with what they were seeing in the community.
Amy, would you mind just to share the adult close contact difference in the guidelines?
Yes, so for the adults, and I apologize because we struck a deal last year with HR. They handle the adults, we handle the kids. We do work very closely together though. So for an adult, for a staff member in our schools, it is still 6 feet. So they will still be, you can have the same person and have a student at 6 feet and a staff member at 6 feet. The student will not be quarantined, but the staff member will. I cannot tell you the rationale behind that. I can only tell you that that is what they have shared with us, and that is what we have to go by. So for symptomatic exclusions, I know this has been something that's ongoing. This hasn't actually changed the automatic exclusions, and then for the secondary symptoms that we typically see. So automatic exclusions with or without fever. This is what DHEC says. If someone has these, they have to be excluded as a COVID-like illness, and they have to go through that either 10-day isolation period, get a negative test, or get an alternate diagnosis from a doctor. It's new or worsening cough, new loss of taste or smell, shortness of breath, or difficulty breathing. Now, there is a caveat to that if it is due to a known underlying condition, we don't have to automatically exclude. So if your child has asthma and they come into the health room and they complain that they have, you know, some shortness of breath or their chest feels tight, and the nurse administers their inhaler and it clears it up, guess what? That was due to the asthma. So we do not have to exclude for that automatically every time your child needs their inhaler. If your child doesn't have that diagnosis though, and they come in and they have a new cough, your child is going to be excluded because DHEC says that is a COVID-like symptom and they need to be automatically excluded. And so you have those same 3 options. A 10-day isolation, you can get a negative test, or you can get an alternate diagnosis from your doctor. The other symptoms, those are the ones I really want to focus on because those are more at the nurse's discretion. Fever, chills, fatigue, muscle or body aches, headaches, sore throat, congestion or runny nose, nausea, vomiting, diarrhea. I can't tell you how many, especially elementary kids, may have had a headache today. because it's the first day of school. They're a little anxious. They may or may not have eaten a good breakfast. They probably haven't had anything to drink all day. So typically, that's not something that I think on the first day of school anyone is going to send someone home for. However, if you come to school and you have a sore throat, a headache, congestion, and runny nose, as a nurse, I would be hard-pressed, knowing what our community spread level is, I would be hard-pressed to excuse those symptoms at this point in the school year. And so our nurses, I just want to reiterate, are professional nurses. They do an assessment of the student. They know what's happening in their school. They know what's happening in these classrooms. They know what's happening in the community. And so when we leave it to the nurse's discretion, we are leaving it to professionals to say, I think this meets the criteria. Your child may be excluded from school based on nothing but a collection of secondary symptoms. And so that's what we really want to communicate with parents, that can happen. And we just want to let everyone know that we're not doing it to penalize anyone. We're trying to do it to keep as many people safe as possible. Are there any questions?
Is this available on the website?
It is.
Okay.
I will say, DHEC is not known for putting everything in one document. So there are several documents that guide what we do. The school and child care exclusion list is kind of the no ifs, ands, or buts. If you're on here, that's it. The guidance documents, like the interim guidance for cases, management of cases in schools, and the interim guidance for K through 12 operations, that's basically how you implement what they are saying in the school and child care exclusion list. But they are all on that website. They are all linked as documents on that website that I referenced.
So,
I've already asked our web person to add her
okay, that's what I was
presentation
asking
as
about.
well, because it is, really concise.
Right, yeah, that was very thorough. So I just wanted to make sure that this was available, what you presented tonight.
Oh.
Yes, all in one place, so people had access to it. Thank you. And
I
Catherine,
just
too.
want to say that your presentation, your sound effects were wonderful.
And then any recommendations representing the voices of all our school nurses around the district around vaccinations and wearing masks?
Yes, please.
What would your
If your
recommendation
child
be?
is age 12 or up, I would suggest that you speak with your child's health care provider to see if a vaccination is appropriate for them and get it if they say yes. If your child is attending our schools, I will freely volunteer. I am fully vaccinated and have been since the very beginning. And I have to appreciate Lexington Medical Center for giving us that opportunity so early in the process. But you see that I have gone back to wearing a mask because it protects me, but it also protects others, because maybe I am one of those breakthrough cases, and I don't want to do anything to anyone else. And so I would encourage every parent to send their child to school with a mask.
And to, during the peak of COVID last year, I had maybe one patient a week with COVID. One a week, maybe one every other week. Now I'm seeing 1 to 2 a day personally. I was, the last 3 of my 4 patients were COVID positive. So we can't run the same playbook that we ran a year ago. I think that's the take-home message. Everybody wants to say, well, I mean, I'm telling you, it's a different story. A virus is a very living thing, and it does what living things do. It wants to survive and it wants to reproduce. And so it's going to find a place to do that. And a year ago, it was adults, vulnerable adults. A fair number of those adults have now been vaccinated. So guess what? Now it's time for the kids. And that's exactly what we're seeing. I've never gotten a daily update from Children's Hospital ever. And I have gotten one for the past month, well, 3 weeks now. We are getting daily updates about the number of students who are in the hospital with COVID, and they're not just there because they've got a little pneumonia. You know, there are some who are pretty sick, and so it's just not the same play it was a year ago. I wish it were, I really do, but it's
And
not.
those updates share the capacity at our children's hospital, so both Prism and MUC, what's their capacity right now?
So capacity, basically 100% of the PICU beds are full. Their ED, just today, they actually didn't have a patient waiting in the ED to go to the PICU. So that means they were holding a patient who needed to be in ICU. They were holding them in the emergency
A
department.
pediatric patient, correct?
Pediatric patient, until a bed became available in the ICU. And then on the floor, they fluctuate anywhere from 85 to 95% capacity. And the dreaded fear is always, the dreaded fear is that you get in a car accident and there's no place for you to go. Okay, imagine that. Imagine that you're sick with something else other than COVID, and you have nowhere to go. I mean, that's a stark reality, and not one we face a whole. It's very rare for a children's hospital to go on diversion. Very rare that they have to begin diverting patients elsewhere, but we have certainly seen it.